Welcome to the American Association for the Surgery of Trauma's video presentation, Trauma in the Time of COVID. This presentation has been prepared by members of the AAST's Prevention Committee. As we come to the close of May, which is National Trauma Awareness Month, we hope this video will increase your awareness of the impact that the COVID pandemic has had on the practice of trauma, as well as some of the concerns we as trauma providers continue to have about the health issues faced by our patients. As mentioned, we celebrate National Trauma Awareness Month every May. The American Association for the Surgery of Trauma, also known as AAST, as well as other organizations, use this opportunity every year to focus our efforts on special advocacy projects designed to improve the health and wellness of our communities. The American College of Surgeons Committee on Trauma, the American Trauma Society, the Eastern Association for the Surgery of Trauma, and the Health Alliance for Violence Intervention, also known as the HAVI, all engage in special projects during the month of May to advocate for increased trauma awareness. During 2020 and 2021, we've had to focus on the impact that the COVID pandemic has had on the care of trauma patients.
COVID has taken a terrible toll on the lives of people on every inhabited continent. It has caused the death of approximately 3.3 million people worldwide as of this writing, more than 500,000 in the U.S. alone, and it continues to ravage some countries more than others, particularly in South Asia, Africa, and South America. Resources continue to have to be devoted to the care of COVID patients, and some non-emergent services have had to be deferred. However, even before COVID, more than 5 million people worldwide were dying due to injury and violence every year. Hospitals that cared for trauma patients had to continue to provide this care during the pandemic. Trauma care is not elective. Furthermore, the COVID pandemic laid bare disparities in healthcare access, socioeconomics, and outcomes. We in the trauma community have long been concerned with patterns of injury and violence that tend to affect more underserved and disenfranchised populations. COVID has reinforced our commitment to making sure that all people, no matter their circumstances, have access to the care they need.
Hello, my name is Rashida Sheffield. I am a medical social worker. During the pandemic, it was very challenging at the hospital I worked at due to there were a lot more violence going on throughout the time of COVID. Another challenging part was family members were not able to come and see their loved ones. During that time, it was a lot more violence, domestic violence, senseless violence among family members, younger children, older children. They were just being shot, stabbed. It was a very trying time.
Many trauma centers reported a decrease in overall trauma volume and unintentional injuries following stay-at-home orders or lockdowns. However, many of these same trauma centers reported significant year-over-year increases in the rates of penetrating trauma, particularly firearm-related injuries. The information about intimate partner violence during COVID has been mixed, with some areas reporting increases in service utilization, such as helplines, and others reporting the opposite. However, it is important to keep in mind that the ability of victims to access services during the pandemic was altered. Victims forced to socially isolate with their abusers may not have had opportunities to request or utilize the services that would have been available before the pandemic. Similar questions are being raised regarding the effect of social isolation on rates of suicide and child abuse. Social isolation is known to be a risk factor for elder abuse. However, with the COVID pandemic, we are still gathering information about the rates of abuse in this population.
I think the biggest impact that we had taking care of trauma patients and their families really was just being there for them. This was a time when family members weren't allowed to come to the hospital to visit. I spent many days using FaceTime and iPads in order to just have some connection between the patient and the family. And unfortunately, I was the last person with family members sometimes at their last breath.
Hi, my name is Jalita, and I am a trauma nurse here. And I just wanted to speak about some of the difficulties that we encountered while taking care of trauma patients during the pandemic with COVID-19. For healthcare providers in itself, it was just having to have the abundance of PPE to protect ourselves to make sure that we didn't contract or pass on the virus to other patients. But I think the most difficult part of it was seeing the patients going through all of these traumatic events and not being able to have any family at the bedside, not being able to have anyone to hold their hands, to tell them they're going to be okay, to tell them that they love them, and to have the support. And that's where we had to step in and we became that patient's family. So that kind of was the most difficult part as a healthcare provider and dealing with COVID and trauma.
Those of us who care for critically injured patients have long been concerned with the effect that violence, injury, and hospital stays can have on the mental health of our patients and the community we serve. There is little question that COVID has exacerbated these issues for our patients and communities. We have known for years that simply being hospitalized in an ICU for several days increases the chance that patients and their families will have mental health consequences that may last for weeks, months, or even years. Additionally, patients may have physical weakness and pain issues as well as cognitive and memory problems, again, simply from having spent time in an ICU. This set is often referred to as post-ICU syndrome and is something that trauma and critical care providers are working on finding solution for even before COVID. Mental health resources, although somewhat scarce, are not equitably available pre-pandemic, and these were exacerbated by COVID. Social distancing and lockdowns, which were necessary to control virus spread, had the unintended consequence of exacerbating underlying mental health conditions and decreasing access to mental health resources for people who needed them most. Those of us who provide care to people affected by injury, violence, and severe illness requiring ICU care have redoubled our efforts to advocate for increases in mental health resources. This includes equitable distribution of mental health resources, mental health care planning, and prevention measures, particularly for potential subsequent pandemics.
The COVID pandemic of 2020 brought about a lot of changes, especially with regard to trauma and critical care. I think we saw a lot of increases in penetrating trauma, and it ultimately changed how, during that time, we went about our typical workflow caring for trauma patients. It changed the emotional tolls that were taken upon patients, their family members, and also as providers taking care of these patients.
Not surprisingly, we ourselves have been affected by the stress experienced by our patients' families and communities. We all strive to provide the best care for our patients. During the COVID pandemic, our workflow changed. Healthcare teams cared for a higher volume of critically ill patients and dealt with death on an almost daily basis. Studies show that this negative health effect with higher levels of anxiety, depression, and stress levels. For some, this led to suicide, as in the case of Dr. Lorna Breen, an emergency department physician caring for patients in the height of the pandemic. Even before COVID, about 400 physicians per year commit suicide. This is unacceptable, and developing strategies for us to prevent burnout, address mental health conditions, and prevent suicide will allow us to care for ourselves and provide the best possible care for those we serve.
It definitely made things more difficult than they already are, whether that be with regard to talking to families and communicating with patients' loved ones, to communicating with the patients themselves, and then also as a provider being faced with a lot of changes in workflow and having to deal with more stress on top of what we already do. Despite that, I think I'm fortunate to be doing the job that I do, and I enjoy my work, and I think this even though things did change with regard to caring for trauma patients, I'm fortunate and grateful to have the job, the position, the job that I do have, and to be able to take care of these critically ill patients.
In addition to the mental health consequences of the pandemic, we know that people from certain communities were more susceptible to poor physical health and mental health outcomes after COVID and trauma. Although advances in the treatment of physical injuries sustained by victims of injury and violence has definitely improved the survival of our patients, we are well aware that this focus is inadequate to fully address the overall health of our patients and their ability to thrive. We know that social determinants of health, factors that exist in our patients' communities and their lives even before they're injured, have as much or more of an impact on wellness and even survival as do the physical injuries. Improving the economic status of a community, improving the physical environment of a neighborhood, and improving the access of individuals in a community to quality education and overall healthcare, as well as employment opportunities. These opportunities work in these areas and have been demonstrated by multiple studies to improve the health outcome for individuals and communities. We also recognize that the way in which we provide trauma care is important. A concept called trauma-informed care is being increasingly integrated into programs in and around our trauma centers. Trauma-informed care recognizes that many of our patients and families come to us with a history of trauma in their lives, physical or psychosocial, and takes that into an account when forming a plan of care. Adverse childhood experiences, or ACEs, can also have a profound impact on the health across the life spectrum, including recovery from trauma. Trauma-informed care recognizes that these ACEs exist and seeks to resist re-traumatization in any form, including in healthcare interactions. It looks like the language we use when we're communicating with each other and with our patients, how we provide a truly safe and calm setting in which we provide care, and utilizing active and intentional efforts not to re-traumatize patients and families by the way that we approach them for care. It also is developing methods that address not just physical recovery, but emotional, mental, and spiritual recovery for our patients, their caregivers, and their families.
One way to combat this is with trauma prevention and trauma prevention services, whether it be prevention in the community to work with families, individuals, and communities to help them understand the problems that may add to the trauma and add to violence, or whether it be in the hospital. So if it's someone that is actually injured and with a violence prevention program, helping them identify what actually led to them actually getting hurt or injured in the first place and helping them correct that. In this time of COVID, things have been very uncertain, and with that uncertainty, violence has increased. And we want to make sure with our trauma prevention program that people are assisted in those ways, whether it be in the hospital or when they leave the hospital to get those key services that may help them not be readmitted or not actually pass away from some further violence down the road.
As you've heard, prevention is a key part of healthcare, be it for trauma, for COVID, or for any other aspect of healthcare. Even during a pandemic, and one might say especially during a pandemic, care of critically injured trauma patients continues to have a significant impact on trauma centers. We are often competing for the same staff and equipment to take care of our patients that are being used to treat pandemic victims. COVID was accompanied by increases in penetrating trauma and firearm violence, both of which tend to require intensive and expensive resource commitment by hospitals and by communities. Our experience of the pandemic has made it clear that it is important to all of us, healthcare providers and the communities we serve, to work and to collaborate together.
But I think during challenging times, the best thing is to work with people who are like-minded and working towards a similar goal. Me and my colleagues wanted the best for our trauma patients. We wanted the best for our colleagues, and we really banded together. And in the end, I think we turned out to be a very cohesive group that we're just very resilient and able to conquer a challenging time such as the COVID-19 pandemic.
What I will say, the positive thing was the medical team worked well together in ensuring the safety of the patients, ensuring the safety of the staff. They ensured that we were always protected by wearing our masks, our face masks, and just making sure that we provided the necessary needs for the patients. And when it was time for the families to see their loved ones, they allowed the family members to do so.
So what can you do to help? One of the things that the COVID pandemic made clear is the importance of a strong public health infrastructure. Having well-staffed public health agencies increases the abilities of communities to provide more accessible resources for mental health, recovery from trauma, victims assistance, as well as for non-trauma related issues such as cancer screening and stemming the spread of an infectious disease like COVID. Contacting your legislators and urging them to support strengthening public health departments will contribute to improving the health of all of us in a variety of ways. Also, advocating to make sure that trauma centers commit not just to great treatment of physical injuries, but also to incorporating compassionate, trauma-informed care will go a long way. Advocating for hospitals to support efforts to improve patients' overall health status by recognizing the importance of social determinants of health and committing to efforts to improve factors that are involved in the social determinants of health. These are all ways that individuals and communities can help us improve trauma care for everyone. If you need more information, you can contact the AAST Prevention Committee on the link listed on this slide. The other important way that you can help us is to take good care of yourself. In addition to staying safe during the COVID pandemic, there are resources available to you if you are a victim of injury, violence, or exposure to violence. For example, the American Trauma Society has a Trauma Survivors Network page that you can go to get more assistance if you are a victim of injury or violence. You can contact your local health department for mental health resources. The Family Justice Center Alliance provides support for families who are going through crises. The National Domestic Violence Hotline can give you resources if you are a victim of intimate partner or family violence. And the Elder Care Locator website can give you resources to help you decide what to do if you feel that you are a victim of elder abuse. Don't try to do it all alone. We'd like to thank you for being part of our presentation, Trauma in the Time of COVID. We hope that your understanding has increased about how trauma care has been affected by the COVID pandemic. We hope also that you have a better understanding of what the trauma care provider community is doing now and hopes to do in the future to serve our patients and our communities. Although we are seeing a light at the end of the COVID tunnel, we ask that you continue to make every effort to keep yourselves, your families, and your communities safe and well. Thank you again.